So the first one I wanted to talk about was testing, but perhaps before we talk about testing for diagnosis, testing for monitoring, can we just set the scene by talking about physiologically what the difference between perimenopause is compared to menopause in terms of kind of women's hormonal profile? And I think maybe then that will inform our discussion on testing.
So perimenopause is an entity shrouded in controversy. And often still not well characterized or established. So if you look at the journey towards natural menopause, and we're not going to probably talk about things like medical or surgical or induced menopause here. This is a natural journey.
Yep.
A woman would generally be having her natural menstrual cycles, monthly periods, normal levels of estrogen, which kind of go up and down throughout the cycle, FSH, LH within normal range. That's before any menopause journey changes have happened. So that's premenopause. The first sort of event or the first phase where things start changing is the perimenopause. So you either go by menstrual cycle change, so periods may change, the cycles may shorten, cycles may lengthen, so there may be gaps between periods, or there may be onset of symptoms. So symptoms such as something is suggesting the estrogen levels are dwindling. So some may have flushy sweats, others may have dryness of vagina, still others may have just mood changes, headaches, migraines, and you can go on and on, almost about 20, 30 symptoms. If those start happening and you're kind of approaching your late 30s, early 40s, then that's perimenopause. Now, how strictly you apply the definition of menstrual changes is an area of controversy. So some purists will say, unless the menstrual cycle has changed, we will not consider this perimenopause, even if symptoms are happening. Others will say no. Menstrual cycles may change much later. The estrogen levels start declining up and down much earlier, maybe 5 or 10 years. And so you should be actually addressing this bit as perimenopause. So we are not finally down to a definition. You kind of take a holistic look and say, hormones start changing, some symptoms appear, periods start changing. That whole phase will be the perimenopause. And finally, a time will come when periods will stop. Very little estradiol coming from ovaries, very little progesterone. 12 months of not having periods, technically that will be menopause. And any time from that till end of life, post-menopause.
Got it.
So peri, then menopause, and then the whole rest of 30, 40 years of life, post-menopause.
Okay. So as you were talking there about the up and downs, and so really to compare and contrast that bit, you were saying that post-menopause really is about being, frankly, kind of estrogen deficient, whereas in the perimenopause, often there's a kind of bit of chaotic nature to your hormones going up and down, and you may not be at one point estrogen deficient. So for women over 45, some practitioners will say, yes, we must test your hormones and we must keep testing them and see where you are. And then the guidelines actually say, we diagnose this based on symptoms. I still get lots of women say, do I need a test? What's your kind of take on that?
So we all see these patients who are very keen to know what's happening with their bodies. And I think I would go by the NICE guidelines here, because over the years, we initially did do a lot of testing. Maybe before NICE guidelines arrived in 2015, many of us tested for FSH levels, estrogen levels, but you could see that there was always no clear-cut correlation. So what we say now is what the NICE says, is we say after 45, if you're experiencing any symptoms which suggest that your estrogen levels are dwindling, then actually go by symptoms, treat quality of life. There's no point in testing at least a random one blood test, because you may be on the day producing very little estrogen, in which case I'll see very low estrogen, high FSH. But a week later, you might have a spurt of estrogen in the perimenopause, and you might be having normal estrogen, normal FSH. So where I catch you on that journey of up and down will give me a result, which may have no correlation to what your symptoms are. So we see women with quite a lot of fluctuation, having no symptoms at all. They're carrying on with their life with no problem. They don't need intervention. But we also see women with little bit of fluctuation having lots and lots of symptoms. And that's what you treat. We are here to help you with that symptoms, quality of life issue.
Absolutely.
So why do bloods? Because I'm really not basing anything on bloods here. I'm basing it on how you feel. And once you start feeling symptoms, that's the time to intervene, whether it's hormones or non-hormonal treatments.
Yeah. And actually, if you catch someone on that day when actually it looks like their estrogen levels and their FSH is fine, you may well actually unwittingly dismiss them and say, actually, nothing's wrong.
Correct.
It looks fine.
Correct.
Where instead of actually treating the patient and not the numbers. Yeah. I've seen a lot and I sent you this video. I've seen a lot on social media, and I think there are more companies coming out now with these monitors where you test your hormones on a continuous basis. So what do you think about those?
Interesting technology. Technology is always good when it helps with things, but we're not there yet. So continuous hormone monitoring has a role. Not yet in terms of managing perimenopause or menopause.
Okay.
Again, for the same reasons that if you keep testing somebody's hormones during perimenopause, let's say they're going from premenopause to perimenopause, they start seeing the fluctuations of estrogen, FSH up and down, slowly declining testosterone in the background. They will see those if you do continuous monitoring. Is that going to change my management strategy? No, I'm going to wait till they have symptoms. I'm going to kind of use HRT or MHT for quality of life purpose. So at the moment, you can do monitoring, you can know more about your body, but it's not translatable into changing clinically actionable management.
Yes.
So what I want the companies to do, the technology people to do is to run it in very good testing settings. See what difference it makes to monitor somebody's hormones for a year or two. Does it mean that they have better clinical outcomes? Does it mean you can intervene early? Now, there are some conditions. For example, if somebody has premenstrual symptoms, somebody is very sensitive to progesterone, somebody has migraines, often this can help. So if you're continuously monitoring somebody's hormone and you see a pattern, at such a time, often there is a peak of estrogen, peak of progesterone, that triggers the migraine, or that brings on the PMS symptoms. That's very useful technology. Then you can try to modulate person's cycle or hormones to eliminate those peaks and symptoms. But you can't apply it to generalize for everybody in perimenopause, menopause yet.
Yes.
So I would refrain from that testing.
Okay, so sounds like it's going to be exciting in the future, but not quite ready yet.
Correct.
Okay, got it. Okay, let's talk about, so the woman who has been diagnosed, she's put two and two together, she's kind of worked out which symptoms she's having, gone to her GP, spoken about it, or menopause specialist, and then they have worked out together, actually, this does sound like menopause. Maybe she's decided to go on to treatment, maybe she decided to do lifestyle treatment, but whatever, she's managing it. And then what about those clinics which will say, okay, if you are going to go on to hormones, we need to now monitor your blood levels to see if you're getting enough. Is that the right thing to do or not?
In certain circumstances, exceptionally, yes, but not as a routine.
Okay.
So again, the same problem comes is often when you test somebody's bloods while they're taking hormones, the absorption of the hormones can be quite erratic. So depending on what time, let's say you take a tablet, you put a patch, you put a gel, you put a spray on your skin, depending on how hydrated you are, what you have eaten, how much is the absorption of the hormones, lot of stress variations, lot of other lifestyle related variations in our blood parameters. And then in perimenopause, you always have the background hormones interfering on top of the HRT. It's really difficult to correlate these in terms of the clinical outcomes or what you see.
Yeah.
So again, your best test to know if hormones are working is look at symptom relief. Because if that's not happening, it doesn't matter somebody is absorbing or not. You got to change something.
Right.
There are better tests for long-term monitoring. For example, somebody's bone density scan, somebody's lipid profile, to look at how much estrogen they are getting and how much benefit of HRT they are getting. So that's why we say routine testing to know how much you're absorbing is inaccurate. Now, if somebody is on HRT on the highest dose and is seeing no changes to their symptom, that's one place where you could have a little bit of usefulness from doing bloods.
Okay.
Because then you can test their bloods and say, actually, the estradiol is very close to zero. That means you're not getting anything in your bloodstream. Let me change the type or the route or the dose.
Okay.
So for women who have no benefits of HRT despite being on a good licensed dose, that's where we often say test. to know if they're absorbing at all.
Yep.
Or those who maybe where we are thinking they're not compliant, to know whether they are taking HRT or not.
Mm-hmm.
But other than that, in routine sort of testing, again, no role for monitoring HRT and how it's going for you with blood tests.
Got it. And so just going back to the point about the bones, if you were on it for that indication, then really it's about monitoring with a DEXA rather than bloods?
You do a DEXA every 2 or 3 years, or sometimes even longer if it's all good.
Yeah.
And that would give you an accurate description. Is your estrogen reaching the bones or not?
Yes. Okay, perfect.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.